Hi, I'm Tim Wiedrich, Section Chief of the Health Resources and Response Section with the North Dakota Department of Health. And this is the Friday edition of the statewide hospital briefing. Tim Blazel with the North Dakota Hospital Association is with us, and let's check in with him and see if he has any opening comments. Tim?
Hi, good afternoon, Tim. I think I'm looking forward to your discussion on the increased staffing that may be coming into the state as it relates to RNs. I know we're working with the Department of Defense and then also a group out of Tennessee. So having some additional RNs come into the state. So I'm interested in hearing a little more from you on that. But again, thanks for hosting today's call.
All right, thank you, Tim. And let's go ahead and dive right on into the agenda, where we're going to be leading off with the Hospital Intelligence Report, and Grace will share that with us now.
Hey, good afternoon. Can you hear me?
Can hear you just fine.
Perfect. Clint, do you want to load the slides? Next slide. All right, so this is where we're currently sitting for our reproduction number for the state, and this was actually estimated about 6 days ago, so this number is actually for the 14th. We do that weekly. It is still above that 1 value, and what that generally means is that the pandemic is still growing within the state. Next slide, Clint. And this is where we're sitting by county. If you can clearly see this, we do see Barnes County, Griggs, and a few other counties have RT values that are above 1.2. But for the most part, most of the counties are hovering just slightly above 1 or between 1 and 1.2. Next slide. And then for the change compared to the previous week, we do see quite a few counties have seen an increase, and Cass, I believe, is one of them, and so is Burleigh County. And those have an increase of about 8% in Burleigh County and about 5% in Cass County. We do see some declines. Grand Forks was one of the counties that did see a decline, McKenzie, and then if you just look throughout the map, you do see the variation in how the direction of the counties is going. Next slide. And this is just an updated slide in terms of the risk of hospitalization. This is cumulative, just an FYI. But overall, as a state, over the last couple of months, and this goes back from August through September, we are seeing that the hospitalization rate of the active cases is about 3%. Next slide. And one of the questions that I've received in the last week or so is what is happening between the October hospitalizations compared to November? Because really, we did have a really high number of cases late October through early November. And if you compare this slide, this is the October positive cases, and what you see as the bar graphs that, going across the x-axis is the age groups, and then the stacked charts are the prevalence of comorbidities in those populations. And so what you see here is what's in the orange, or at least the dark red, is the number of individuals who report, or at least the percent of individuals reporting as having 0 comorbidities. The yellow is the individuals with 1 comorbidity, and the green is 2 or more comorbidities. And so for October, and Clint, if you want to go to the next slide. Overall, what we're seeing is the number of new cases in November are generally healthier than the ones in October. And that, especially when you go by age, because we do know that really that intersection of age and comorbidities is where you expect to see the highest risk of hospitalizations. For our November cases, we have observed that they're generally healthier compared to the cases that we saw in October. And that could be playing a role in seeing the lower hospitalization rate that we're currently seeing. Next slide. And as I mentioned last week, this is just an update from the slides from last week. But really, the infection rate is growing in our neighboring states, just as it is growing in North Dakota. And so in terms of projecting where your patients will be coming from or where you might have the potential to send patients, just just an FYI, even in our neighboring states, we are seeing increasing number of cases and increasing positivity in, especially in South Dakota and Montana as well. Next slide. And this is just the updated projection. So our model is still projecting this increase of cases that ideally would peak around January, like the 1st of January, end of December. And what you see, that's what you see in the blue line. And then what you see in the orange is the actual daily cases. And so that shows you how well our model is projecting compared to our actual cases. Next slide. And this is the projection for the current hospitalizations. Again, we are seeing a bit more, it's not as perfect as we expected, and the November cases are skewing that a bit. And as I explained, in the last few slides, some of that could be based on the populations that are currently acquiring COVID being a little bit healthier compared to what we saw in October, and that could be skewing our projections. Next slide, Clint. And then lastly, I just wanted to highlight, this is an update from last week. Really, the probability of exposure to at least one case is very much, as we go into the holidays, Thanksgiving is next week. There is potential for this getting worse, depending on how people choose to act. And really, with crowd sizes, if you pick 5 random North Dakotans, there's at least an 18% chance, based on our current RT value, of at least having one case that's of COVID present. And so if you have a dinner of 5 people next week and that individual is present, that does have the potential to, skew our model, and basically this could be much worse. And so I just wanted to highlight that. And then also some of the data that we're seeing around masking. It does seem that, for the data that we have around close contacts of masked individuals, there is about a 44% reduction in the risk of transmission. And so these two factors could really take us in combination, could take us in either a positive or negative direction. If people are, out there socializing, not, having social gatherings and things like that, and not masking, that could change the trajectory of our predictions. But, if people stay home and they, comply with the executive orders that were just recently put out and everyone is masked, we do have the potential to really change the trajectory of the projections that we're seeing. And so I just wanted to include this just to make sure that, you all know that, this is not a crystal ball, and it's very much dependent on human behavior. And depending on how people choose to act over the next couple of weeks, that could either, lead to an explosion in the number of cases, and then, of course, the cases needing hospitalizations, or it could go in the opposite direction, which is we actually start to see this reduction that, some of the other states have observed when it comes to when they've implemented mask mandates. I believe that's all I have, Tim.
Thanks, Grace. Well, let's go ahead and have some conversation now about the projected surge staffing that is occurring within North Dakota. We've been fortunate to secure 2 sources of additional registered nurses and LPNs to assist our response. First, I'll talk about the Department of Defense response. A while back, we had filed with FEMA a request to receive additional nursing staff within North Dakota, and that request was tasked off to the Department of Defense. Earlier this week, we began receiving advanced team members from the Department of Defense, and specifically the Air Force, to begin setting up the processes that they need to have in place to have the 60 nurses that we requested actually arrive. And so we are expecting those 60 nurses to be arriving this weekend. And once we complete their processing in and providing them an orientation of the state, and the military completes its processes, we would expect to begin actually creating assignments for them and deploying them into the hospital settings within the state early next week. And on Monday, we'll have further updates in terms of where those processes are at, how we're progressing, what the assignments are in terms of how those resources are being allocated. So there'll be more information about the Department of Defense nurses coming up again during this program on Monday. But then in addition to that, we've also secured services through a contract agency called Eminent Consulting out of Tennessee. Now, we had shared a number of requests, not requests, but a number of agencies through a variety of sources, including this program and the Hospital Long-Term Care Association. Eminent was one of those. We selected Eminent because of their fast response time and several other factors as well. And so they are in the situation where they also will be sending us our requested 60 nurses, and we expect to be receiving them this weekend as well. And the same process that I just described will be applying for them. So that process will consist of us doing an orientation, getting them set up, getting the assignments actually made, and those 60 will be deployed through a combination of long-term care facilities and also hospitals as part of that process. And we expect that deployment also to be occurring early next week as well. There will be, again, more information about the Eminent staffing as we conduct this program again on Monday, so I'll be able to drill into more detail at that time. But we're very fortunate to be able to have this roughly 120 nursing staff come in and supplement the staff that's already existing within North Dakota. Just to refresh your memory, we have a COVID response team that's comprised of temporary nurses. They're not temporarily nurses, they're temporarily working for us. And that process, we've hired 166 of full-time and part-time nursing staff that we've been deploying over the last several months as part of that process, but we'll be able to substantially increase that through these resources. And there's the potential that we'll have even more resources coming in through these mechanisms as well. So very good news. We're very excited about that and more to come. Let me turn now to Cody Pinks, who has some additional information for us about the reporting processes and some of the information surrounding how that process is moving. Cody?
Hi.
Hi, Cody.
I'll wait for my slides to pop on up and I'll get started. Oh, let me turn my camera on. Okay. So I'm going to go over the last 3 tabs that are in HE Standard for the Long Federal Survey. And it is the diagnostic testing tab, the serology testing tab, and the influenza testing tab. I'm not going to go through like each of the questions or anything like that, but I'm just going to go over some questions that I have received from a couple of hospitals. So around the diagnostic testing, a hospital had asked, should hospitals report rapid antigen testing done on their machine in-house under the diagnostic testing section? And with all these testing ones, I always verify the answers with HHS to make sure I'm giving everyone the correct answer. But through the CARES Act, it does require reporting of every diagnostic and screening test performed to detect or diagnose COVID-19. This should include reporting antigen testing done in-house under diagnostic test data. And then with the serology tab, some of the questions I got around that from hospitals was, should serology tests that are sent out to a different lab get included in the numbers or not? And per CMS guidance, hospitals that send tests to any of the 6 commercial labs that are listed there at the bottom, or to the state public health lab, they do not need to report those tests. It's only tests that are done in-house or sent to private labs or performed by commercial labs that are not listed in those 6. So everything else, you would report, but do not report anything that comes to us or that goes to any of these commercial labs. And then kind of the biggest change was the addition of the influenza questions. I haven't received a whole lot of questions around this, but one of the things that HHS had highlighted is that if someone is known to have flu because they were tested earlier in a clinic and then the retest isn't done in the hospital, should that patient still be counted? And if that patient has lab-confirmed flu at the time of admission or has a lab-confirmed test within the prior 14 days, whether inpatient or outpatient, they should be counted for reporting. And so one of the other big things that they really stressed in my last call is that with this particular question package, the same patient may be counted multiple times. And I'll give you an example. So if you have a patient that is both COVID and influenza positive, that patient would be counted in 3 different areas. So that patient would be counted with the patients that have influenza. It would also be, that person would be counted with patients that have COVID. And then that patient would also then be counted for those that have COVID and influenza. It was supposed to be just a really quick snapshot for CMS and HHS to see how many people have influenza, how many people have COVID, how many have both. So for that particular patient, that person would be counted 3 times. I know it's broken out whether they're inpatient or ICU, but just so people are aware, you could have one person counted in multiple areas in this particular section. So that ends what's right now part of our federal reporting. Of course, anyone can reach out to me at any time and I'll help try to answer their questions. If not, I have a really good connect with HHS that answers pretty reasonably quickly. So thank you.
All right. Thank you, Cody. We're about to go to the VP3 team, but before we go there, I'm going to go ahead and ask Clint to bring up the survey information that we have. As you know, we collect a series of standardized questions, and I'll go ahead and get that started now. And if you would, please just go ahead and respond to those questions as they're coming up. And I do have to leave for another obligation, and so Angie Strand of our office will be taking over the hosting of this meeting for the rest of this meeting. And Angie is the interim director of our hospital preparedness program. And so after we come out of the VP3 team, Angie will be leading us through the rest of it. So let's go ahead and turn our attention now to the VP3 team, Roseanne, Seth, and Jan.
All right, it is just Roseanne today. The others are obligations have called them away. But I just wanted to give a couple of brief updates. The VP3 team has been part of the daily huddles that we have with the Big Six facilities, the Big Six hospitals in the state. And it really is just, again, to get a feel for where the bottlenecks are as far as the beds. And we hear pretty loud and clear that there are issues with, I know the critical access hospitals trying to transfer into the bigger six hospitals. And so we are having some discussion about how we can help streamline that a little bit better, because we know that when a critical access hospital is trying to transfer somebody, we know that it takes a lot of time and a lot of phone calls in order to make it happen. And that's time that most people don't have. So I hope we can come to some kind of an idea of what we might do to be able to alleviate that and help the critical access facilities. I think it would go a long ways. And the hospitals, I have to say, really want to do this. They're the ones that brought it up and are suggesting that there's a better way to help you guys. So look for that to happen down the road. And then also wanted to mention too that as far as for long-term care facilities, we have posted as of yesterday, talked about the tactical call with long-term care, the updated guidance. Skilled nursing have to follow all of the CMS guidelines that get put out in their memos. And so we've updated all of those guidelines for visitation and also for the testing process. And that's all available online for the public. It's on the State of North Dakota website. And I think lastly for today, we do have a call with CMS to talk about visitation for nursing facilities. You know, it's something that has become we hear about it quite a lot. And I know that you guys represent your communities all across the state. And the thing that gets talked about right now is that nursing homes just can't have any internal visitation. So we're trying to work with CMS to come up with a way to have what we used to do as outdoor visitation, create a safe designated space indoors that would meet certain criteria so that there could be some family visitation with these residents. Otherwise, it's just not going to happen with our county numbers the way they are and the outbreaks everywhere that there is in the community spread. So with that being said, that's a wrap on our week. And if anybody ever has questions, feel free to call us at any point. We'll try and help you out. Thank you.
Thank you for that. So we'll go ahead and move forward with the hospital rounds. If you have any specific comments that applies to your facility, go ahead and provide those comments when I call your region. So we'll start with Fargo. Okay, moving on to Jamestown. And Bismarck. Moving on to Dickinson. And what about Williston? Minot? Devil's Lake? And any comments for the Grand Forks area? Okay, well, I'm not hearing any comments. If you do have comments and the meeting ends, you can feel free to email me and I'll get the answers for you if I don't know them, or I will just answer your question outright. So we will go ahead and wrap up this meeting today since we don't have any further comments. Oh, yes, before we wrap up, be sure to finish out the survey and I will send out that information with additional information on the IAP later today. Thank you.